I'm Dr. Ali, a cardiologist with 30 years of clinical experience. Today we're going to discuss pulmonary embolism, the modern paradigm. Here we move beyond the binary low risk, high risk, PE, no PE, pre-existing condition, no pre-existing condition paradigms. Historically, PE was considered as provoked or unprovoked. Provoked would be considered triggered by, for example, a prior major surgery or fracture. Unprovoked were considered to be idiopathic. There was a major flaw in this. Patients, for example, with a minor transient risk, with a greater than 4-hour flight, um, and with major reversible insults, they were all put into one category. Now, the modern paradigm includes a recurrence risk framework. The recurrence risk ladder goes from major transient reversible factors such as major surgery, more than 30 minutes of trauma, and you would stop anticoagulants at 3 months. Minor transient, which would be temporary triggers, travel more than 4 hours, estrogen, you assess bleeding risk versus recurrence and then decide. Persistent would be ongoing factors like acute cancer, inflammatory bowel disease, autoimmune conditions, and you would consider extended therapy. Number 4 would be no identifiable factor, idiopathic, and you would extend the anticoagulation in these patients. Now, before we used to consider massive PE, submassive PE, low risk, things along those lines. Now we disregard the submassive category altogether and we use the ACC AHA categories instead. Category A is subclinical or asymptomatic pulmonary embolism. Category B is symptomatic with low clinical severity, SPECI 0 points. Category C is symptomatic with elevated severity with RV strain and biomarkers being positive. Category D is inpatient with incipient cardiopulmonary failure. Category E is cardiopulmonary failure with hypotension or cardiac arrest. Now, for patients with a clinical profile that is low risk, that is asymptomatic patients or symptomatic with low severity with a SPECI score less than 0, you could manage them outpatient with oral DOACs and discharge them early from the emergency department. Whereas patients with a clinical profile where they are normotensive but objective signs of distress with an SPECI score greater than or equal to 1, patients who have the triad of strain, which would be abnormal RV function or biomarkers, abnormal RV function and biomarkers. These would be these require mandatory hospitalization and low molecular heparin administration. Now, category D patients and category E patients, category D would be worsening gas exchange or progressive tachycardia or normotensive shock. Category E would be persistent hypotension, obstructive shock, or cardiac arrest. These patients need ICU admission, advanced mechanical rescue, systemic thrombolysis, catheter-directed thrombolysis, mechanical thrombectomy, or ECMO. These are your highest risk patients. Now, you should have pulmonary embolism response team or PERT teams. AHC category C, D, and E patients go to the PERT team. Category C goes to telemetry, anticoagulation optimization. Category D goes to the ICU, systemic thrombolysis and embolectomy, or mechanical thrombectomy. This is a true paradigm shift. Now, with regards to long-term management, you should have vigilance and watch out for chronic thromboembolic pulmonary hypertension threat, and routine follow-up should be done. Follow-up echocardiogram should be considered. The goal is not just surviving the acute clot, but preserving long-term cardiovascular function. Thanks for watching. More to follow.